for a couple of minutes about what they're doing, their work in LMNA, and then we're going to have some questions. So, Dr. Bonne, would you like to introduce yourself?
Sorry. Yeah, I'm Gisele Bonne, working at the Myology Institute in Paris. And I'm leading a team who work on the genetic and exploration of the mechanism of the disease in order to identify some potential treatment. So I'm a basic researcher, and I'm working on the running diseases.
Great. Dr. Worman?
Hey, hi, Howard Worman. I'm a professor of medicine and pathology and cell biology at Columbia University in New York. I've been working on nuclear envelope, nuclear lamins for about 30 years, before there was any diseases linked to these genes and proteins. And now we devote a good portion of our research trying to understand mechanisms of how mutations in genes such as LMNA cause different diseases, including muscular dystrophy and cardiomyopathy.
Great. I don't think Dr. Bang has joined us. Dr. Bang, are you with us? Okay. Dr. Konersman, can you introduce yourself?
Certainly. I'm Chamindra Konersman. I am a neuromuscular specialist at UCSD, which is University of California, San Diego, and I also work at Rady Children's Hospital. I am mostly a clinician, and I take care of a lot of, I shouldn't say a lot, but I take care of a cohort of LMNA patients, both adults and children. And I'm well versed in the genetics and the pathophysiology. And I am getting into more and more clinical trials, although not specific to LMNA, but in general clinical trials. And I do collaborate with a lot of physicians and other scientists to help further the research for my patients.
Great, thank you. And I am Rachel Alvarez. I work for CMD, the Director of Operations, and happy to be with you all today. We also have Sabine Deschassenet on the line. Sabine, you want to introduce yourself?
Okay, hi, I'm Sabine Deschassenet. I have been volunteering with CMD for a good 4.5 years now. I've been the Director of Development for a year as well now, and my background in sciences, I'm kind of, as everybody at CMD, we are all wearing several hats. We interact with the patients, we interact with donors. We just try to move things forward here and support the community.
Great. We also have our CMD's new research director, Gustavo Diaz-Chapolsky. Gustavo, would you like to introduce yourself? Gustavo, you having sound issues? Okay. You should see a pop-up there, Gustavo, to share your microphone. All right, we'll come back. So first I would like to have our panel talk a little bit about the work that they're doing at LMNA. And let's start with Dr. Bonne. Can you give us a brief overview of your work?
Yeah. So, first of all, I study genetics in the way I identified the first mutation of the gene that is mutated in LMNA disease. and I identified this back in 1999, and since we have identified several other disorders, and among which the congenital muscular dystrophy related to this gene. And after that, in order to understand how the mutation leads to the disease, we have started to study the mechanism of those mutations. And for that, we have reproduced the mutation in mouse in order to have a mouse model that develops the disease in order to study this mouse. And once we have got those mice, we have analyzed them and observed that they were developing some disease that could, in a way, be like the human disease. And now, with this mouse model, we are trying to find the mechanism and to cure those mice first. As if we are successful with slowing down the progression of the disease in the mice, then we will have the proof that we can propose some treatment to make some trials with patients. So for that, we have made those mice, and those mice develop both muscle disease and cardiac disease. Oui, someone is listening. And I will not enter in too much detail about what we explore on the cardiac disease, because I mean it's essentially what Worman will explain us later on. At the current stage, at the current time, we are using those mice and cells also from patients to try also to remove the mutation with some gene therapy approaches, and to, in that way, to try to cure also the disease. But this is a very long term approaches, and we are still at the very beginning of this step. I don't know if it's clear for everybody. Don't hesitate to ask questions if you wish.
Definitely. If anybody has any questions, you can either speak up or type into the chat window for Dr. Bonne. Okay. Well, that's while we get that sorted. Dr. Worman, can you give us a brief overview of your work in LMNA?
Okay, so I'll be brief. Like I said, we've been working on nuclear envelope diamonds for about 30 years now, and what we're focusing on now, and it's, we've been working with Gisele for a long time too, is also looking to a large extent at mouse models and trying to figure out pathways that are operative in cells downstream from the LMNA-C gene mutation that are abnormal and may be leading to disease. And we hope that by targeting these pathways with specific drugs, it will lead to benefit in patients someday. And so far, we've come up with several different drugs, some in one class and some in some other classes, that at least have beneficial effects in mice with LMNA mutations. These are mice that Gisele made about 10 years ago that we've been working on, and we found that certain drugs that act within certain signaling pathways, they're called signaling pathways in cells, lead to improvement in the mice. Certainly not an overall cure, but a prolongation of life and improvement in some heart and skeletal muscle function. Other than that, we also are still doing some basic cell biology and biochemistry of nuclear lamins. we're looking at how alterations in lamins that are associated with diseases like congenital muscular dystrophy affect basic cell processes, such as the positioning of the nucleus within muscle cells, the migration of muscles, to try to find other avenues that may be suitable for therapy in the future. For example, there's effects in muscle cell precursor migration into a muscle to keep maintaining the muscle in a good. We've been looking a little bit at that process too. Again, most of what we're doing is been done in cells and in mice. We haven't translated anything into patients yet. Such work we hope to do in the future, but I like to say when we're at this stage, be cautiously optimistic, but still a lot to do to make sure that anything will ever be useful for patients. And I'll stop there.
Thank you so much. Does anybody have any questions for Dr. Worman? I have some other questions queued up here. I think the question on everybody's mind, first and foremost, is how realistic is a cure or treatment for LMNA in the near future? I know that's a really hard question for you guys to answer, but I think and I don't expect you to give us kind of in terms of years, but and how optimistic are you for our treatments for LMNA?
Do you want me to start and be very frank?
Sure. Yes,
I think a total cure is a long way off. I can't put years on it, but it's not going to be in 1, 2, or 3, or 4, or 5 years. Hopefully in the next, 3, 4, or 5 years, perhaps there'll be drugs that'll provide some benefit, slow the progression of the disease, improve the heart or soul function a bit. But, I think a complete cure, it's going to take a decade or more of real lot of research. And again, I'm talking research that's going to take resources. So, well-funded research done by good people.
Okay. Dr. Bonne, do you have anything to add to that?
Oh, I think I'm in line with what Howard said, as we are collaborating together. And the first option potentially to go to trial and proposal to patient would be some drugs to slow down the cardiac disease or any other aspect of the disease. And this is what we are working together with Howard at the present time. The other aspect that I mentioned before about gene therapy, which targets not the consequence of the mutation, but the primary presence of the mutation. This one is even more longer approaches, and this would necessitate even more time than proposing some drug to slow down the consequence of the mutation. So I think the very first option would be to slow down the effect of the mutation, and that's what we are doing with Howard, with some development of some drugs for that.
Okay, great. Some other questions that we have. I don't know if anybody has. Go ahead, Gustavo. Hi.
Hi, this is Gustavo, Scientific Director of CMD, and I totally agree with Dr. Bonne and Howard Worman. But in the optimistic side, scientifically, we are in a moment where, well, we already know many of the mutations causing the disease, and we have many tools to study the pathogenesis of the disease. We have animal models, we have cell models, and so this is from the optimistic side that we have great scientists and improving tools to understand the disease.
Gustavo, can you tell everyone briefly about Dr. Bang's work?
Dr. Bang, she's a cell biologist and she works at the Sanford Burnham Institute in La Jolla, California. She's been derived pluripotent cells, stem cells from humans, from human cells, taking fibroblasts from humans. She can make them pluripotent stem cells, and then she can derive those cells to different types of cells, like neurons, muscles, etc. So she now has taken some of fibroblasts of patients with LMNA. She was able to produce muscle cells and cardiac cells, and she is trying different small molecules, looking for targets that can be modulated by drugs. So she's having that work in progress right now.
Great. So Joanne is from Australia. She was asking if there will be a gene therapy trials will be open to participants who have used steroids. Is that going to be a factor in clinical trial design? Any of you?
Well, this is Howard Worman. I'll say there are no clinical trials yet, but I doubt that something like it would matter.
And this is Chamindra Konersman. So there's been this question of whether to even use steroids in LMNA, and there have been some case reports of patients having improvement in strength after being placed on steroids, and that might have something to do with the inflammatory changes present on a muscle biopsy. Just like Duchenne muscular dystrophy patients respond to steroids, there have been some patients who've been put on steroids who have improved. That being said, we don't have any clinical trials or long-term efficacy data on whether steroids are beneficial in this specific mutation. And I have to say that not every single neurologist that takes care of LMNA patients, I don't know of them routinely putting patients on steroids. Speaking for myself, I hesitate to put patients on steroids even though there might be a short-term benefit, because I don't know if there's going to be any long-term benefit. There are plenty of conditions where short-term course of steroids have been helpful, but not in the long term, and those are diseases that they have the long-term efficacy data for. Has anybody else had any experience placing patients on steroids to begin with?
This is Gustavo.
Yeah, it'd be interesting to hear from the families on. Go ahead.
I could comment about a couple of surveys your CMD made in, I think it was in March, Rachel. That's okay? Is that true?
Yep.
It was March this year.
Absolutely.
From 7 patients, 6 of them are reporting positive effects and benefits better than the side effects. Only 1 stopped the treatment a year after it started because the side effects were overwhelming compared to the benefits. And this survey goes 3 patients from 2 from Spain and 1 from Argentina. They have short experiences, 2.5 months to a year, I think, a year and a half. But then there are US patients and 1 patient from Australia, and all of them have experiences from 3 years to 5 years and still reporting good effects. But that's the only data I see.
I think I've read some reports as well, and I think what we need to probably do is actually do an actual clinical trial
Yeah,
where we're
yeah,
giving steroids and actually prove that it's beneficial and that it actually improves strength. And,
exactly. This is only individual reporting from patients and survey particular patients and their physicians.
So, Dr. Konersman, what do you feel about families who are wanting to give it a try? Is there some kind of steps they should take? Do you advise against it? What is your general thoughts on people wanting to try that?
I'm usually only against initiating a medication if actual data to show that it doesn't benefit a patient. So that would require the presence of data. However, if there are some scattered reports, which I know that there is for LMNA, of steroids potentially helping, I am willing to do at least a course of the medication and take very good measurement of the patient's muscle strength using dynamometry and other clinical measures that we typically do. If the patient's ambulatory, we would do a 10-meter walk test. We would do a 4-stair climb. Following those measurements, those time measurements over time, what I would actually do, very similar to an actual clinical trial, but I would just do this in the clinic with the help of my physical therapist. So I'm not usually against it. But in my little kids who with CMD due to an LMNA mutation, perhaps I should actually initiate that, especially with my one kid with the head drop. But I wanted to answer one of Ms. O'Brien's questions about the gene therapy, and perhaps Dr. Bonne and Dr. Worman would be willing to help me with this. Is it true that if we were to do a gene therapy, let's say you're going to replace the entire LMNA gene, doesn't it actually need to not just cross the cell membrane, but also the nuclear membrane? Is that right, Dr. Bonne and Dr. Worman?
Oh, if you put the gene in, and the protein will go to the right place. I mean, the question is, you have to get rid of a gene with a point mutation and put in another gene, and that's not easy to do.
Mm-hmm. Yes, you have to. Okay, so it doesn't need to necessarily cross the nuclear membrane. Just getting into the cell is sufficient, and it'll automatically do what it needs to do and actually get translocated into the nucleus.
The protein will go to the right place.
Okay.
Well, all genes will go to the nucleus. I mean, need to be in the nucleus. So.
Okay.
Gene therapy will not be easy.
Dr. Bonne, did you have something to add on that?
Sorry?
Did you have something to add on that, Dr. Bonne?
So, as Howard said, the gene would go at the correct place in the cells. It's not a matter because the nuclear envelope is affected by the mutation. It doesn't matter. If I try to answer the question that I read about the fact that FDA recently approved exon skipping therapy for specific Duchenne mutation, and whether this could apply to LMNA mutations. Well, exon skipping might not work in the case of the LMNA-C gene because this gene is rather small, and exon skipping means that you remove all parts of the gene, and we cannot remove big parts of the lamin gene, otherwise it would be even worse. So what we need to do is to remove the mutant gene, and as Howard said, to put back the correct gene. And it is what we try to do at the current time in my team, is not to totally remove the mutant one, but decrease as much as possible its presence and put back the wild type, the normal one. And we use techniques that are quite close to those techniques used for Duchenne. So the fact that FDA had approved this type of approach for Duchenne, it's a step further, it's a step forward for gene therapy as a mean in neuromuscular diseases, but still for lamine disorders, we still need to prove that it works in patient cells, in a tube, in the mouse model, as a whole individual. And once we are able to demonstrate that this works, we will perhaps try to move forward. But still, we are at the very, very, very beginning of this type of approach. But it's one of the aims that we try to develop. But as I said before, this will need quite a time before we can achieve it.
Mm-hmm.
Dr. Konersman, can you talk a little bit about the side effects from steroids and why families may need to be a little bit more cautious about the use of them and monitoring ongoing use of steroids?
Sure. Steroids come in the form of prednisone, prednisolone, which is solution, as well as deflazacort, especially in Europe. The side effects include, especially in children, is excessive weight gain, which typically comes in the form of increased appetite. So the weight doesn't come out of nowhere. It's because of increased caloric intake, because the child is always hungry, because prednisone is a stress hormone ultimately, and it does make people eat more. So there is increased weight gain. As a kid, or if an adult with LMNA was put on steroids, I do need to monitor their blood pressure. I monitor it even in my children as well, but it tends to be more of an issue in my adult patients. I also need to assess for the risk of developing diabetes, especially in adult patients. It also will thin out the bones. It's medically called osteoporosis or osteopenia. And so there's an increased risk of developing fractures of the bone. The fractures can happen because a child or an adult can fall and break a long bone. It can even result in what's called spontaneous fractures, where you're not really doing anything and all of a sudden a bone breaks, or they're simply being moved, transferred from a bed to a chair, and something that's broken in that process. It also will thin out the skin as well and makes it more friable. It can break easier. And in some children, not all, it can make kids very hyper. I classically have a lot of experience starting patients who have Duchenne muscular dystrophy on steroids. And those kids, especially if there's a predisposition to have a cognitive issue, either autism or decreased cognitive function because of the mutation, there is a higher risk of developing mood disorders such as depression or anxiety, or the autism getting, or typically getting worse. LMNA patients are cognitively very normal, so running into too many mood issues tend to be less of a problem. So those are the basic things that we worry about when we put a patient on steroids. There is also an element of stunting of growth if you were to start it on a child. However, I have to say that in general, in muscular dystrophies, a shorter stature is usually better. And that's simply because of the height and the forced contraction occurring over a shorter length of bone. And it's characteristically, and we found this out while we were doing the Duchenne muscular dystrophy clinical trials, the taller patients tend to get weaker faster. So those are the main side effects that we look out for. And I agree with Ms. O'Brien, it's difficult to figure out how long to keep a patient on steroids once it's initiated, especially in a LMNA patient, because we don't have long-term efficacy data. But I would have to weigh the risks and the benefits. So, Ms. O'Brien, I would recommend that, if you think that the benefits of the medication are still better or higher than the risks to your child, you can talk to your neurologist about keeping your child, your son, on the medication.
Great. I think that was very helpful. I think some of the other questions that we had in the Facebook group were along the lines of the heart condition and what are the signs that the heart is starting to not perform as well as it could be. Could you explain a little bit about the measures that are done to indicate whether or not there is starting to be difficulty in the heart?
Yes. So what we typically do is we do EKGs just at during the clinic visit, but more importantly, you have to do Holter monitoring, where you strap EKG to the chest and you actually take the little device that records the heart rhythm for a long period of time, namely at least 24 hours, sometimes even longer, and you would do this at least once a year. If the heart doctor, the cardiologist, finds something that's worrisome, they might do the Holter monitoring or the long duration EKG with more frequency, perhaps every 6 months or so. So symptoms that we watch out for are patient feeling dizzy, like there's like a butterfly in their chest, like they're having what's called palpitations. They might even experience chest pain. They get really short of breath even with a little bit of movement. Fortunately, the congenital muscular dystrophy form of LMNA has a lower incidence of heart issues, but a higher incidence of respiratory issues. Whereas the adult form of LMNA does have a high incidence of hearts. So most of the heart issues come in the form of an abnormal rhythm, which is what we're going to capture on the Holter monitoring. We would also do echocardiograms or MRIs of the heart to see if the function of the heart, the ability to pump, is preserved or not. The adult forms of LMNA are more worrisome for heart issues, and we do monitor that very carefully. And I would say that almost every single patient develops heart issues by the time they're in their 7th decade. The childhood form, you would watch out for heart issues as they're approaching the teenage years, even though you do screening before that. I start screening for heart issues soon after I suspect the diagnosis, even if it hasn't been genetically confirmed just yet.
Great. Dr. Worman, do you have anything to add to that?
Not really. No, I just think you have to keep an eye on the patients and check their heart once in a while, and that's all. I mean, unfortunately, there's not much, yet to do other than the standard of care for these heart problems, like perhaps put in, pacemaker or defibrillator and use standard of care heart failure drugs as of now.
And one more thing that I've been running into, especially in my adult LMNA patients, is a cardiologist or somebody who didn't realize that it was an LMNA mutation and there's a high risk of fibrillation arrhythmias. They would just put in a pacer. And a pacer, unfortunately, doesn't save a patient's life. A pacer can keep the heart rhythm in going at a specific rate, but you need, in LMNA, if a pacer is at all needed, I recommend to my cardiologist, who actually already knows this, that always a pacer with a defibrillator be put in, because the defibrillator can actually save the patient's life, and they have a high need for a defibrillator at some point in their lifetime. Do you agree with that, Dr. Worman?
In general, yes. I'll just say it's more black and white when to put in a pacemaker. Some patients don't have the conduction defect and they're having occasional ventricular arrhythmias, and it's hard for the cardiologist sometimes to pull the trigger if the left ventricle isn't dilated yet. So in general, I agree, but I don't see a lot of these patients, but often the decision when to put these things in is quite complicated.
Mm-hmm.
It's not risk-free. You're still putting a device and so on. But I agree, if you're putting in a pacemaker, put in a defibrillator most likely. And I think Gisele has published something on this if she's here.
Yeah, I'm not a cardiologist, so I just say that I hear from our cardiologist here in France and what we have discussed last year with Georgia Brugada in Spain. For adult patients, our cardiologist has demonstrated the added value of defibrillator rather than pacemaker, as it was pointed out just before, because there is a number of patients, not a lot, but a number of patients who start their diseases by sudden death. That means they had nothing and they die suddenly because they actually carry LMNA-C mutations. These are for some adult patients. So having in the affected in the family member of the patient some genetic strain, sometimes it's proposed even before there is a true connection defect to have a prophylactic emission of defibrillator. So this is for large family of adult form with cardiac prevalence. For the congenital form of the disease, what we discussed last year with Georgia Brugada in Spain is that now they have some small device that can be implanted in a young child to monitor 24 hours a day the cardiac rhythm, and this can be very useful to detect the earliest signs of the cardiac disease in the young children. So this is still some survey that is currently being made, and we will see in a few months from now if this is very positive to monitor this heart rate in a prophylactic way.
So Dr. Bonne, were you referring to the natural history study that's being analyzed right now?
I think it's a natural history. I don't have the outcome of this natural history study developed and followed by Georgia Brugada.
Okay. And then you had also led the effort to conduct a retrospective natural history study based on medical records from a number of sites around the world. Do you have any idea of kind of give us an idea of what you were looking for in that data and when that might be published?
Okay, so we have initiated 1 year ago or so an international survey for the retrospective study of early onset and congenital form of Lyme diseases, and we have collected clinical data from 190 different patients who had an onset of the disease before 5 years of age, and we are still working on this collected data with statisticians to see what would be the exact natural history of this patient. So I just got some feedback from Professor Carsten Worman a week back, and there is still work to sort out all the data. As you can imagine, to manage very detailed clinical data from 190 patients, it's kind of a large amount of work. And what we try to see is whether we can identify some early signs that could predict in a way the outcome of the muscle and the respiratory function, as well as the cardiac dysfunction in this type of patients. But for now, we don't have finished to explore the data. We hope within the few next weeks to have more clear view of all this.
And do you feel like the data that was collected will be able to allow you to start looking at genotype-phenotype correlations, so as far as where the gene is located and what the prognosis or the progression of the disease would be?
Yeah.
Or do you feel like we're not there yet?
What we know, what we have observed, but it's not yet completely statistical, is that the patient who had early onset compared to the patient who had an adult onset do not have exactly the same type of mutation and not located exactly the same way on the gene. So that are the very first correlation between what we call the genotype and the phenotype. So there is a type of a specific subtype of mutation that seems to be more severe with earlier onset than others. But still, we are far to understand all these details.
Okay, thank you. Sergio was asking about the Brugada study in Spain. Wanted to know if there's any news. I know that she's not ready to publish yet, but I know that she has been inserting the link monitor by Medtronic into her patients and has been receiving data. Is that correct?
Yeah, it was Georgia has been leading, and we will have a meeting in October in Paris that will gather the Spain team, the team of Worman in US, and our team in Paris, and we will make an update of what are the current project developed and what are to have an update of the different ongoing projects. And Georgia should present the ongoing study for the cardiac management.
Great. So we will have another.
No detail yet.
Right.
Just have
gotcha.
the program meeting.
Okay. So we will have another webinar probably in November that will kind of summarize the meeting to kind of let families know where research is headed in the next year and what the plans have been. So we'll talk about that at the next webinar. Dr. Konersman, could you kind of briefly describe what the best way to optimize care would be for a young person with LMNA? So make sure that families are doing everything they possibly can to ensure that they stay as healthy as possible.
Certainly. So there's a lot of symptomatic treatment that we do for LMNA patients. First and probably foremost is that the patient, in addition to being seen by a pediatric neurologist or a neuromuscular specialist, should be also seen regularly at regular intervals by a cardiac specialist. Ideally, it's a cardiac specialist who has some expertise in LMNA or has some idea of what happens in the Emery-Dreifuss muscular dystrophies, which means that a lot of cardiologists who don't have experience in muscular dystrophy just automatically assume that it's just a cardiomyopathy. So they need to understand that in LMNA that there are cases of sudden cardiac death, and that rhythm monitoring is actually probably more important. So regular follow-up with a cardiologist. And then I do institute things like regular stretching regimens and physical activity that the patient can tolerate. One of the hardest things is in my dropped head syndrome patients is what to do about the dropped head. Some of the patients, they fall very dramatic, they fall like a tree, and there's no righting reflexes. They don't put their arms out to break the fall. So when they fall, they actually bump their head pretty hard. And unfortunately, because of the dropped head, putting a helmet on just makes the whole thing worse, because now the head has to support even more weight. The neck has to support even more weight. So being very careful when the child is walking tends to be very important. And I've resorted to, even just to keep the patient mobile, but to improve their safety, that they always have to walk with someone by holding someone's hand. I have 2 such kids who have a hard time walking, and they have a tendency to fall, and they have dropped head syndrome. So we do regular stretching. We engage in physical therapy. A lot of my patients do aqua therapy because of the buoyancy of the water. They enjoy the treatment, and it keeps them active. And then one of the most important things is also keeping them intellectually engaged at school. Even though they have a muscular dystrophy and they look different from the other kids, these kids are intellectually very normal. And teachers need to be aware that they are able to do cognitively everything that another child can do who doesn't have a muscular dystrophy. So I have not been initiating steroids regularly in my patients, but perhaps after doing some pre-reading for this webinar, maybe I actually should be doing that. But I will talk to some of my other colleagues about their opinions on initiating steroids in LMNA patients. And so that's it. Routine cardiac monitoring, and then regular exercise and stretching, especially of tight joints, to maintain their muscle function and mobility. And they also get seen by a physiatrist, also known as a rehab doctor, for improvements in the way that they can in terms of devices that they can get to improve their mobility.
So this is Howard Worman. Could I do my 2 cents in about steroids I've heard a lot about today? The truth about steroids is we just don't know. And I think there needs to be a double-blind randomized trial. It can even be a crossover
Dr.
trial.
Worman, I think you just cut out.
Hello? Hello?
Yep, start over, please. You just cut out. We got you now.
Am I back? I was saying for steroids, we really have to do a clinical trial. And if there's not a lot of patients, and there aren't a lot of patients, it could be a double-blind crossover trial, where the patient doesn't know if they're getting placebo, which is a dummy drug, or steroids for, say, 6 months, and the doctor doesn't know which they're getting. You do objective measurements. You can probably get meaningful data, 15 or 20 patients. And since the community is so small, and you guys have access to so many of them, you know, I think it's something that would not cost too much to set up, and could give very, very meaningful results in a relatively short time. So I think
you feel like that could be established at multiple sites?
Excuse me?
I know that a clinical trial on steroids is something that Susanna Quirano-Roy wants to set up rapidly. As you just say, Howard, it's not that much to organize. It's not that much to do, but we need to do it properly to be sure of the outcome of this therapy.
Right, I agree, and it should be blinded at some level. And
do you feel like this is something that could be accomplished at multiple study sites, or would it have to be only a small number of physicians participating.
Rachel, I think it will need to be multiple study sites because LMNA, especially if we were going to do the congenital muscle diseases form of it, it's going to, the frequency of the mutation it's low. It needs to be a multi-site trial.
And with a multi-site trial, do you feel like we could get a consistency as far as, adhering to the protocol and actually getting data that is usable?
You need good investigators. Sure, you can.
Mm-hmm.
Just got to get the right people to participate.
Mm-hmm. If Mr. Piedra is still on the line, I was able to actually look up. He asked a question about exon skipping. I wondered what restoration of exon skipping, if it has any potential in LMNA. I was able to find an article that said that antisense oligonucleotides for the skipping of exon 5 in LMNA could theoretically restore function. Well, I shouldn't say restore. It has the possibility of treating specific laminopathies. And however, skipping exon 5 is a low frequency. It's a small number of patients that it applies to. So doing a treatment for a small number of patients is usually very difficult for a pharmaceutical company or anybody to invest in that. The reason that exon skipping worked for Duchenne muscular dystrophy, namely, let's talk about 51, is that it applied to 13% of all DMD patients. So that's a lot of patients across the globe. So that is why that specific exon skipping was able to gain momentum. So, Mr. Piedra, if you're still on the line, I'm not sure that exon skipping is going to be a viable option that'll capture a lot of the LMNA community. So I'm not sure it'll work.
This is Worman. I don't think you can skip any exon. I mean,
Okay.
You can sometimes delete a single amino acid and people get sick. So, I mean, you're not going to be able to skip an exon and make that people better. 5, 10, any exon.
I know this paper that was reported with exon 5 skipping in lamins will demonstrate some slight positive effect in cell culture, but they have not achieved validation in vivo in a mouse, for example, because mice with a deletion of exon 5 will not would probably develop a disease. As Howard said, any domain of lamin carry mutations in every every domain of lamin have been found to be mutated. So
okay,
it's hard to believe that you can remove a piece of lamin without any harm for the molecule. This paper was a kind of proof of principle that the technique could work, but to translate this approach in patients, I don't trust it at all.
Okay, Dr. Bonne, yes, you're quite right. It was done on human cells. It wasn't an in vivo. It wasn't an actual animal model or anything like that. Agreed. And yes, it eliminates a much smaller gene, and it seems like every single nucleotide is important.
What you have to keep in mind is that dystrophin is a very big protein,
yes,
and with a lot of repeat, and you can, in a way, remove some repeat, you still have a functional protein. Lamin is a much shorter protein, and it's not a modular protein, so you can hardly imagine to remove a part of it, because it would be really detrimental for the function. And I think it's what Howard wants to say as well.
I agree. Yes, you're not going to be able to skip an exon in here.
Okay, thank you.
Okay. So we have one other question here. Is there any medications working for treatments now for heart issues? Are there any drug interventions that are currently being applied to patients with LMNA for the heart?
I could say for adults, in adults, they're looking at a drug called a P38 inhibitor, Array Biopharma. The data have not come out in concrete form, so nobody knows. In mice, we and others are looking at several different drugs that seem to benefit the heart, but we have to jump from mice to men, and that's always a bit challenging. So far there's been one clinical trial in adults with a P38 inhibitor that was based on work that we did in mice. So there's hope that some of these drugs that work in mice will go forward.
Addie, I know your comment about so little hope. I feel like there is hope. I feel like we have a really great scientific team working on these issues, and they are focusing on the heart because that is kind of the linchpin, so to speak, for this specific disease. And I think that as small as this subtype is, considering the prevalence compared to the other subtypes, I feel like we are really, really fortunate to have as many people working on this disorder as we do. So I have hope. I have hope for LMNA.
There is a lot of hope. Just let's not have false hope and realize it's going to take a lot of hard work and resources. But there's a lot of hope. It's just going to take time.
I agree with that, Mr. Piedra. Don't give up hope. Don't despair. Every single condition is slightly different. And because of that, we have to tailor the way that we are going to approach something. That is what Dr. Bonne and Dr. Worman are working on. They're working on the molecular aspects of this condition so that we can actually do something about it. You have to learn each condition on its own. Each one has different effects on the cell. So it takes a level of understanding. And you have to also remember that the congenital muscular dystrophy form of LMNA was really only described just a few years ago. And we're already talking about potentially drugs that can alter different chemical pathways in the cell. That is a big, that's very fast actually in medicine. I mean, Duchenne muscular dystrophy we've known since the 1990s. And only now do we have a single medication for some of our patients. So it's going to take time, but we can't cut corners. We have to do this right. So don't give up. It takes effort from all of us.
So if I may say, for Duchenne, it has between the identification of the gene and the FDA-approved drug, it has been 30 years. But Duchenne has been, let's say, the first disease in neuromuscular field to go through all the steps, and it has opened a lot of doors for other neuromuscular conditions, and lamin is among those. And we take benefit of all what has been developed for Duchenne and try to adapt as much as possible the different paths that they go through. Of course, it's adapted to the context of lamins, and it's a very complicated context. But trust us, there is a lot of research team working in the field, and although we know that the time of research is not the time of the patient, we try to do our very best to make everything possible to go in the good direction and as fast as possible. But as Howard said, we need to be very cautious and not to propose something too fast that could make harm to the patient, rather to make benefit to them. It's our responsibility also to propose correct treatment that has been well validated before and to be sure that they would be the most secure as possible for the patient.
Jonathan Alvarez is asking how many adults with LMNA. I think that we are not in a position to actually give true prevalence. This disorder, as Dr. Konersman has indicated, a lot of people are diagnosed when they find out they have cardiomyopathy and they're missing the whole component of LMNA. Dr. Worman, do you have anything to speak towards prevalence in adults with LMNA?
I can just tell you our best guesses that's been based on self-published series and based on a couple countries where they have some prevalence data. We've estimated in the US it could be anywhere from about 1,500 to 5,000. So it's a big range, but it's rare. It's not ultra rare, and there's a big range on what the actual number is.
Yeah, if the question, oh, sorry.
Sorry, I was
go ahead.
To say that in France, we have a registry of patients having LMNA mutations, and we have identified around 500 patients carrying LMNA mutation, and more than 80% of them have cardiac disease. So this is for France.
Gustavo, what were you saying?
No, I was just going to say that if the question was referred to the number of patients in the clinical trial for the drug that Dr. Worman mentioned from RA, the clinical trial was with 12 patients, I think, and they are opening another trial now.
Okay. Well, we're coming to the end of the hour. Does anybody have anything to add, or should we go ahead and wrap up?
I just did a search on PubMed to see if prevalence data has been published. Unfortunately, Mr. Alvarez, it has not been published, just like the other doctors had said. But the estimated frequency in the United States is roughly 1 in every 25,000, but that's an estimate based on other congenital muscular dystrophies. It's not specific for LMNA.
Right,
so we don't have
that
the data.
All the subtypes.
Yeah, that includes a bunch of other genes besides LMNA.
Okay,
So that's just
well, I'd like to thank everybody for joining us today. Our panel of experts, Dr. Bonne, Dr. Worman, Dr. Konersman, we very much appreciate your time and your summarizing of your work and advice for the families. I think that they very much appreciate it. We're all looking forward to your meeting in Paris in October, and we are excited to see what's next. So, again, thank you so much, and I hope everyone has a great day.
Yeah, thank you.
Thank you, everyone.
Thank you.
Thank you. Bye.
Bye-bye.